The head of the World Health Organization has arrived in the eastern Congo city of Bunia, the epicenter of one of Africa's most alarming Ebola outbreaks. The World Health Organization says that more than 900 suspected cases have already been reported, with over 200 deaths. But doctors on the ground warn that the real number could be much higher. What makes this outbreak dangerous is the strain itself. The Bundibugyo variant has no effective treatment and could kill as many as half of those infected. And cases have already crossed borders into Uganda, raising fears that the outbreak could escalate beyond the region.
WHO Director General Tedros Adhanom Ghebreyesus has been traveling in the Democratic Republic of Congo to help coordinate the country's response to the Ebola outbreak. On Saturday, he arrived in Ituri, the province worst hit by the deadly virus. Speaking to reporters, the UN health chief said that while the international community was helping the DRC government cope with the outbreak, at the same time, the local response was critical.
Yes, the international community is involved under the leadership of the government of DRC. And at the same time, community ownership is important. That's why we're here to discuss with the community to see how the response is, running, and if there are challenges to help.
Local communities are facing immense struggles to contain the virus. This Ebola treatment center in the town of Bunia had to be rebuilt after being burned down earlier this month by protesters angry over the burial of an Ebola victim. The attack led fearful families to hide sick relatives at home, further increasing the risk of spread.
We often forget about family members when things get difficult. Some family members understand the epidemic, but others refuse to acknowledge the existence of this illness. So we have to often ignore false rumors.
The Bundibugyo virus, the current strain of Ebola, has no approved treatment or vaccine. The infection is transmitted through close contact with sick or deceased patients' bodily fluids. Many health facilities are reporting a severe shortage of protective and support equipment as they grapple with a surge in suspected cases, primarily among women, who are traditionally the caregivers.
Nurses in hospitals are usually women. So if a woman is exposed and becomes infected, she'll naturally pass the infection on to those around her. And the first people to be infected will be her children.
As the number of Ebola cases in DRC continues to rise, authorities in neighboring Uganda are trying to stay ahead of the outbreak. Uganda has closed its official border with the DRC, but risks remain that infections could spread through other porous border points.
Jason Kindrachuk is a microbiologist and associate professor at the University of Manitoba. When the news broke of the current Ebola outbreak, he was optimistic that it could be contained quickly. Now he's changed his mind and told me why.
So a lot of my optimism was born really out of the folks on the ground that are leading this on the front line. And that really comes down to my Congolese colleagues from the National Institute of Biomedical Research and folks that work in the Ministry of Health across that country. And this is certainly not their first foray into Ebola virus disease by any stretch, and certainly different variants of Ebola. So I think the optimism comes from the fact that you have literally the best people in the world that have the most experience in the world battling this at the front line. Certainly, really good understanding of the virus and transmission dynamics, all these different things, within the country. So, in being involved in past outbreaks in the DRC, what we've seen is very, very quick identification of cases, quick contact tracing, containment of the outbreak, and limited spread to other regions. That was the piece of the optimism that I had. Also hoping that we gained a lot of experience coming out of the West African epidemic in 2014. Now things have changed. We're not dealing with one location. We're dealing with multiple locations, a lot of cases that aren't being identified in an area of the world that, quite frankly, is very difficult to get to and very difficult to be able to track people's mobility. So I think what we're seeing right now is really, I think, many of our worst considerations of what could happen if this was able to move along at the pace that it is.
So that was a lot of information there. Let's break this down a little bit more specifically for our viewers. What are the biggest obstacles to containing the spread of this particular strain of the Ebola virus?
Our biggest consideration right now is identifying cases of infections and as well those close contacts that people have. The way that I would reflect back on it is, we're hearing, cases as they're being presented in the media and being presented in reports. A lot of those cases have still not been able to be diagnostically confirmed. So the PCR tests are still lacking, and that's not because of a desire to get those done. It's because of an ability to get reagents and the PCR tests themselves out to these particular regions that are quite remote. The other piece, again, too, is also getting into the communities and convincing people to come forward. That's not an easy, an easy job. Certainly in West Africa, we faced many considerations with people that were not comfortable with coming forward with self-reporting. People that were concerned that if they took somebody to a healthcare center or an Ebola treatment center, they would not see their relatives or family members again. Those are many of the same things that we're dealing with again, and that takes really boots on the ground, door-to-door communication with communities to talk about this, and that's not something that can be done within minutes or hours. It oftentimes can take days, weeks, or months to get communities kind of galvanized around that idea of the importance of self-reporting.
Now, who is best prepared to do that type of community outreach? Is this something that international organizations can do, or is this something that health workers, local health workers, have to take on?
Yeah, great question. I would argue it's actually the folks that are local on the ground. So we have a lot of experience working in this area, myself, and certainly led by work from our Congolese colleagues working in Mpox. We faced a public health emergency of international concern in DRC and in moving into Eastern Africa over the last few years. A lot of the work that we did was in highly stigmatized communities. That wasn't best dealt with myself or others from areas outside of the DRC going door to door. It really was finding peer leaders, community leaders within those areas that understand the importance of getting information out, but also understand how to talk with people, right? And it's not a difference in terms of people's understanding or putting it into lay principles. It's being able to talk in local dialects and with a trusted figure that community members can look to and ask questions from.
Now, let's focus on those healthcare workers on the ground for just a second. You have more experience with that than probably anybody we've talked to recently. So what exactly is the reality like for them? What do they struggle with? And, we've been hearing about funding cuts for them in recent days. Is that playing an issue in the fight against this current strain of Ebola?
Yeah, all of this is kind of coming together in one very, very large storm, right? I can reflect on the things that I experienced in West Africa at the time of that epidemic. And certainly I don't think that those things would be, very different from a lot of other folks that were on the ground. This is a horrible disease. I think one of the things that maybe gets lost in the discussion about case fatality rates and the number of cases is what this actually looks like when an individual is infected, the need for supportive care that they require, and just the horrible, debilitating conditions and symptoms that those individuals are in. Healthcare workers have to deal with that. In often cases, these could be people from their communities. It could be people that they have a linkage to, but it's their country members. It's not lost on them. These are people that are in very, very desperate needs. And I think it's, you get that perspective. You see families that are infected. You see children are infected, older adults that are infected. Those images do not get lost on you. And these are things that do not happen overnight. They in many cases can take days to weeks for somebody to either recover or succumb to disease. So I think a big piece of this is trying to appreciate that for healthcare workers, they're experiencing this on the front line really from minute to minute. And when cases continue to increase, when there is not the availability to distribute a therapeutic or a vaccine really quickly to try and curtail that ongoing circulation of disease, it can become a little bit debilitating from a mental health perspective of thinking, how do we ever get ahead of this?
And finally, if you could, we are seeing cross-border transmission already. And of course, the World Cup is just around the corner. How likely is this outbreak of Ebola to become a global problem?
Again, I'll reflect back on that 2014 to 2016 epidemic. We had, close to 30,000 confirmed infections. Around 40 to 60% of those were fatal infections. We saw a few cases of disease outside of the area of Western Africa. Those were very limited. We did see ongoing, circulation in communities. They were identified very quickly because of good access to testing, certainly good access to supportive care. To me, the risk continues to be extremely low for any sort of an outbreak or an epidemic to occur outside of that very pivotal area in Central Africa. But it's the complete opposite within the region right now. Certainly things are expanding. We know that these borders are very porous. The limitation for us, though, is when we think about this idea of putting in protections and reducing the ability of people to either get into the area or to be able to get back home after they've participated in healthcare activities. It's going to be harder to draw on the international community to get experts to go into the area. So to me, I look at this and say, we have a very specific problem in very specific location. We have to focus on those areas of circulation and try and get that under control, and then also appreciate the distances between either international airports, international connectivity thoroughfares, and look at this again from a very specific manner.
All right, that was microbiologist Jason Kindrachuk from the University of Manitoba. Thank you very much for your expertise.
Thank you.
And we can now bring in Christian Lindmeier. He's a spokesman for the World Health Organization, WHO, and joins us from Geneva now. Christian, what difference does the WHO leadership on the ground make to the response? Why is your boss there?
Well, thank you very much, Gerard. It's a really important visit. It's to show that the international community stands with DRC. The authorities in DRC have a long history with Ebola, and they know how to fight Ebola. I think it's their 17th outbreak or something like that. But that specific strain, the Bundibugyo, as you said, is one where there doesn't exist vaccine and there doesn't exist any specific treatment. So everything has to be shepherded in. Recent budget cuts have decimated the health facilities in that specific area on top of it. There's a mining activity in the whole wider area, and rebels are fighting for ground there. So it's nearly civil war circumstances in some of the places. So a perfect cocktail for people movement, for uncontrolled movement, for restriction of access. It is a fight. It is a fight against time also. We're racing behind the virus right now. But with this support by the Director General and therefore the whole international community, I think the authorities will win this one as well.
You mentioned budget cuts. Do you have enough staff, equipment and isolation capacity on the ground there?
A lot of this is being shipped still. We had colleagues in the early days reporting that where there's supposed to be stocks of PPE, the personal protective equipment, there was nothing. Not one piece, not two pieces, nothing. And that's definitely a problem because the distances from Kinshasa are far, the capital of the DRC. 1,700 kilometers by air and 3,000 by road. Everything has to be brought there. And that's on airlines which also don't want to go into a troubled Ebola-ridden area. So everything is a challenge, but international aid is rolling in. Let's not forget that. All the UN partners, the NGOs are getting supplies in. No equipment, supportive care treatment, tents, and so on and so forth. So aid is rolling in, but it needs to be set up. Laboratories have to be set up to test on the ground, not to have to ship every specimen back down to Kinshasa. So it's a huge effort, but it's on the way.
Let's talk about containment. What is being done to prevent further cross-border transmission? We're hearing that there have already been cases in Uganda.
So we know that there are cases in Uganda. We've had, I think, the 9th death reported now in Uganda. But unfortunately, we have to suppose that this has spread a bit further already. That specific strain has only been detected 4 or 5 weeks after it had started, because the authorities tested for the more common Ebola Zaire version, which showed, of course, negative. Now, for containment, we have basically two options right now, apart from the supportive care. First, the communities are immensely important because they need to understand again and again how to protect themselves, how to protect their loved ones, how in case of a loved one is sick, how to treat them, not to touch them, not to wash them in the same way they used to do, not to kiss them, hug them, to give them comfort, which is very difficult if you have somebody suffering from the family. So that's an important point. And yes, cross-border movement. The International Emergency Committee recommended already no border closures, but exit checks. So check for symptoms, check for temperatures. And of course, somebody who feels sick or is sick should seek help and not travel. But that is in an area where there's distrust is high because of the ongoing disruptions and war. The distrust to anything official is high, and that complicates issues as well.
Now, this particular strain, is it more difficult to contain than other strains? Is it more difficult to fight?
It would be similar to fight. The problem is we don't have a vaccine yet. There's only 3 candidate vaccines, and while they're already in a candidate status, because Bundibugyo is not a new strain, but it has had a couple of cases each year, yet it takes about half a year at least to get that into production state. Similar for treatment. There's no approved or no licensed treatment for that. So this is difficult. In that sense, it's more difficult to fight because we can't put the ring vaccination that was called before, like we use in other Ebola cases. That's not possible. So we have to rely on supportive care and the community work at this point.
Now, how confident are you that this outbreak can be contained?
We are confident. After all, it's a fight we know. It's a fight against the disease we know. The authorities in Congo are really, really strong in fighting Ebola. They have specialists in Kinshasa who are all engaged. But we haven't seen the worst yet. We all believe that this is the beginning. This will get worse before it gets better, but it will get better. That's what we all think.
Now, before I let you go, what's the single most urgent priority right now?
Getting all the equipment on the ground and being able to talk to the communities in the far away and remote places and convince them of the necessary steps.
Thank you very much, Christian Lindmeier there from the World Health Organization in Geneva. Thank you, Christian.
Thank you.